Yes, thank you very much for joining. So I think today
Okay.
that we have very nice two guest speakers. So one is from Novosibirsk from Russia. He's a great vascular neurosurgeon. The name is Professor Andrei Deboy. So maybe I think Sachin, you want to introduce them?
Okay. So, good afternoon, good evening, and good morning to all the friends, delegates, panelists, faculties, chairpersons, Dr. Sachin, and I welcome you all to this yet another ACNS YNS webinar, which we are conducting every second and fourth Sunday, especially for the education of the young neurosurgeon. And today we have another interesting yet another session wherein we have our guest speaker, Professor Andrew Dubovov, who is the professor of neurosurgery at Federal Neurosurgical Center, Novosibirsk in Russian Federation. And we always have one young neurosurgeon who will be talking on the interesting topics, and at the end, which will be followed by the discussion. The young neurosurgeon who will be with us is Dr. Ishkuatov Garyat from Uzbekistan. And to chair this session, we have Professor Ibrahim from Bosnia. And we have two discussants, Professor Klaus from Germany and Professor Fawad Pirzat from Afghanistan. And as usual, we have our chief patron, our president, Professor Yoko Kato, along with us. So I would request Professor Yoko Kato to say a few opening remarks to encourage the young neurosurgeon, and then we'll start the webinar.
Okay, so once again, thank you very much. Professor Pirzat, how are you? So I
Salam,
find, yes, thank you. Thank you very much for joining today. So at the beginning, just I want to thank you very much, Dr. Ibrahim, and also the Dr. Kraus for the chair and discussant for the today's YNS webinar. So two great speakers. We will very much expecting their talk. Thank you very much.
Yes. Thank you. So I would request Professor Ibrahim to give us a permission. Shall we start the webinar, Professor Ibrahim?
Yes, I think so. If the Professor Dubovoy ready, maybe we can start with his lecture. Later on, I hope that others will also enjoying with us. Professor Dubovoy, your presentation is ready, and I hope that during your session, Dr. Gairat will also enjoy with that and continue after your lecture. However, we can continue with discussion after your lecture on, even if we get some kind of question by the audience, so we can stop you and ask you during the lecture. I think so we can start, please, Andrei.
Okay, thank you, Professor Ibrahim. Now I can start to share my screen. Do you see my screen? Yes?
Yes, perfect.
Okay, thank you. Thank you. First of all, I want to ask many thanks to Professor Kato, to Sachin, and to Raja, and other organizers for inviting me as a speaker at this interesting webinar. And today we will talk about such difficult pathology as a complex MCA aneurysms, which can be treated with revascularization methods. Some words about epidemiology. According to various publications, the prevalence of MCA aneurysm ranged from 40% to 43%. In our series, 32.6%. From 17 to 45% of all MCA aneurysms are complex. In our series, 35.2%. According to our data, the incidence of complex MCA aneurysm requiring various methods of revascularization is 23%. It's a very big percent. Patients with complex middle cerebral artery aneurysm may present with intracranial hemorrhage, mass effect, epilepsy, cerebral ischemia, and of course, incidentally found. mortality of this disease varied from 65 till 85% within 2 years, including rupture or re-rupture. And 5 years combined morbidity and mortality rate about 80%, very high percent. What mean a complex aneurysm of MCA? Of course, this is an aneurysm with wide neck, sclerotic and calcified dome and the neck of the aneurysm, multilobular aneurysms with 2 branches coming from the dome of aneurysm, and partially thrombosed aneurysms, previously treated aneurysm called or clipped, and of course giant aneurysm, we mean complex aneurysm too. What problems await a neurosurgeon during operation on complex MCA aneurysm? First of all, this is incomplete closure of Klip's jaws, Klip's dislocation from the neck of aneurysm to parent artery, thrombosis of the cerebral arteries and its branches, distal thromboembolism, perforating lenticulostriate arteries, occlusion, and brain tissue injury. All of complex MCA aneurysm we divide into 3 categories regarding their localization. First of all, this is M1 segment aneurysm. Then next group, this is aneurysm of bifurcation M1 segment. And of course, distally located aneurysms, including M2, M3, M4 segments. Regarding their shape, we divide all of complex MCA aneurysm to fusiform. More often, we see this aneurysm in M1 segment. Saccular aneurysm, more often this aneurysm located in terminal part of M1 segment in bifurcation, and of course combined form, combined shape, saccular fusiform aneurysms. At this slide, you can see different revascularization techniques to improve the results of surgical treatment of complex MCA aneurysm. First of all, the simple low flow ST-MCA bypass, single or double barrel. Then a middle flow bypass between internal maxillary artery and MCA. This bypass need to use interposition graft, a short interposition graft, about 4-5 centimeters to reach the MCA territory. The interposition graft can be arterial or venous, and then you can perform in some cases a high flow bypass. High flow bypass performing between external carotid and MCA territory. This bypass need a long interposition graft around 20, maybe 22, 23 centimeters. The graft can be arterial or venous too. Next option, intra-intracranial bypass. In different situations, intra-intracranial bypass can be as a reimplantation, reanastomosis, anastomosis in situ, anastomosis with short interposition graft, and of course combination of different bypasses and different bypasses and different anastomosis. Before perform treatment, we need to calculate of the quantitative blood flow needed to revascularization of the MCA territory. Before surgery, we can perform balloon occlusion test, and during performing surgery, we can use methods of measuring of the invasive blood pressure in MCA territory, and another method using ultrasound flowmetry to check volumetric blood flow through arteries. In our conception, for revascularization of the distal part of MCA territory, we need only around 50 milliliters per minute blood flow. This conception described by Amin Khanyani in 2010. Our conception. To choose a type graft, we use this algorithm. If STM's branches is good developed, we can use single barrel bypass or double barrel STA-MCA bypass. If STA branches is bad developed, we use for bypass internal maxillary artery. If internal maxillary artery is good developed, we can perform middle flow bypass. Is internal maxillary artery and STA branches bad developed, we perform high flow bypass in very rare cases in our clinic. Today we have different bypass options. Which options to choose in which situation? First of all, very simple. We can use STA, of course, because this artery is very simple to harvesting from subcutaneous flap. You can use one branch or two branches of STA and can perform a single or double barrel STA-MCA bypass. On the left picture, you can see single barrel bypass, and the right picture, you can see a double barrel bypass. In cases when the STA branches is injured or bad developed, you can use internal maxillary artery for revascularization of MCA territory. You can see internal maxillary artery, red color in this picture. You can see interposition graft harvested from radial artery. You can see this graft as blue color. And distal anastomosis switching to M2 of MCA. In cases when internal maxillary artery bad developed or very thin, you can use high flow bypass with radial artery graft. The proximal anastomosis in high flow bypass cases performing with external carotid artery, and the bypass from coming from external carotid to MCA region under the zygoma or above zygoma. You can see a radial artery graft. This is a long graft around 20-22 centimeters, and this type of revascularization performed very rare in our clinic. Very difficult problem. This is a treatment of fusiform aneurysm of M1 segment. Why? What is the problem of surgical treatment? You know about many perforating lenticulostriate arteries coming from M1 segment. Of course, if M1 segment changed and you see fusiform aneurysm, very often you can see lenticulostriate arteries coming from the aneurysm. This is very difficult to treat this type of aneurysms. Next, the MCA territory is the final part of the cerebral vascular system because ACOM and posterior communicating arteries located more proximally, and distal part of MCA territory has only anastomosis, only cortical anastomosis between anterior cerebral artery and posterior cerebral artery. Usually this anastomosis is not good developed. Our treatment conception. First of all, we check the flow through the M1 segment or all M2 branches. You can see a small video of the surgeon checking the flow inside M1 distally the fusiform aneurysm using Charbel probe. Then we perform revascularization of MCA territory distally the aneurysm. In this case, you can see suturing, the moment of suturing distal anastomosis between radial artery, interposition graft, and M2 segment. Then we can close M1 segment before the aneurysm and check the flow through the bypass or bypasses. In this case, through the M1, through the radial artery graft. If quantitative blood flow is good, you can use proximal clipping of this aneurysm or distal clipping. In some cases, you can use trapping of this aneurysm. On this picture, you can see proximal clipping. This case shows distal clipping after the aneurysm. And trapping the aneurysm is the best option, but not every time the surgeon can perform this option because sometimes aneurysm consists lenticular-straight arteries. In these cases, only proximal or distal clipping. For example, at this picture, you can see a fusiform N1 MCA aneurysm, and the method of treatment of this aneurysm, the surgeon choose making double barrel ST-MCA bypass and aneurysm trapping. This aneurysm don't have lenticular straight arteries coming from the dome, and the trapping option is the best option for treatment of this aneurysm after revascularization. You can see double barrel ST-MCA bypass and ST arteries coming to M4 segments. Next example, you can see giant fusiform M1 MCA aneurysm. In this case, surgeon choose a treatment option, to revascularize the distal part of MCA territory using IMAX artery bypass with interposition graft from harvested from radial artery. You can see interposition graft between IMAX artery, and you cannot see the giant aneurysm. You can see the clip placed just after the aneurysm before bifurcation of M1 segment. This is a follow-up of this aneurysm disappearing. MRI before surgery, CTA before surgery. Just after surgery, the next day, you can see this aneurysm and partially filling of the aneurysm, but this filling is not very high. 5 months later, you can see partially filling this aneurysm, and you can see giant aneurysm. And 3 years follow-up, the patient doing very well. This is a female patient. She coming to school. She's a teacher, and you can see the aneurysm at the CT angio. And inside the capsule of the aneurysm, you cannot see the thrombotic masses. Next example, fusiform N1 aneurysm, previously treated in another clinic. We choose in this situation high flow bypass and distal aneurysm occlusion. We don't perform a proximal occlusion because this segment is around this segment. We saw many adhesions. We perform high flow bypass between external carotid using radial artery graft. We perform DSA next day after surgery. You can see a good feeling of M1 segment and lenticular-striate artery coming from the fusiform aneurysm. This patient cannot has a neurological deficit after surgery, and you can see good revascularization of distal MCA territory without any perfusion abnormalities. You can see high flow bypass and clip just after the aneurysm. And this is 6 months later follow-up. You cannot see the aneurysm. You can see high flow bypass coming to MCA territory, and the aneurysm is totally disappeared. And next option, intra-intracranial bypass and treatment of complex MCA aneurysms. You can see a small fusiform aneurysm located on the anterior temporal artery, but this small aneurysm has a rupture in anamnesis a few weeks ago before patient coming to us. And you can see the 3D CT angio. You can see this fusiform aneurysm, and you can see anterior temporal artery coming through the from the fusiform aneurysm. This is very difficult to treat this small aneurysm, but we need to treat this aneurysm. This is operation video. First of all, I placed a clip to the neck of the aneurysm, and then I cut off anterior temporal artery, and this artery very easy to reach to M1 segment, distally the aneurysm. I preparing this artery using fish mouse technique to making anastomosis between M1 segment and this artery, and to side fashion. I skip temporary close M1 segment. This segment don't consist of lenticular-striate arteries. It's very good for me, for patient. Then we perform a flushing of the lumen of this isolated segment and suturing the anastomosis between anterior temporal artery and M1 segment. Starting blood flow, this artery was reimplanted to M1 segment distally the aneurysm, and aneurysm clipped as a saccular, not fusiform, as saccular. And then we delete this aneurysm and try to investigate the wall of this aneurysm in our laboratory. And next day we perform CT angio, and you can see this is reimplanted artery, feeling very well, patient without any deficit. Next, about intraoperative management of the patient. Routinely, we don't use heparins in intraoperation period. To brain protection during period of temporary closing parent artery, we increasing the blood pressure level by 20% from initial level. In postoperative period, all patients are required to admit in a single antiplatelet therapy. In our clinic, we use aspirin 100 mg per day, 5 days before surgery and 6 months after surgery. To check the exclusion of the aneurysm, in cases of proximal or distal clipping, we perform CT or CT angio next day after surgery, MRI or CT angio 6 months later. In a few cases, we perform digital subtraction angiography. Treatment of a complex M1 trunk aneurysm. In this case, you can see complex M1 trunk aneurysm, fusiform. In this case, we perform eclipse reconstruction of this aneurysm using a bypass between STA and MCA as a protector only. This bypass need only on period of temporary clipping of parent artery. You can see making of STA MCA protection bypass using a cortical branch of MCA. You can see we use small clips. These clips used to treat of AVM. We very like to use these clips to close small arteries, temporary close of small arteries. Then we close M1 segment inflow to the aneurysm, and we of course close both of two segments and temporary close. During the period of closing, the STM MCA bypass perform revascularization of distal part of MCA. Then I puncture this aneurysm, evacuating blood from inside this from lumen of this aneurysm, and perform a clip reconstruction. You can see M1 segment. This clip reconstruction, you can see protection bypass between STA and MCA, and of course you cannot see big aneurysm, and you can see M1 lumen. In conclusion, I need to ask about the technique of cerebral revascularization in surgical treatment of complex MCA aneurysms allows to expand possibilities of surgical treatment without losing of radicalism. Bypass in combination with parent vessel occlusion is a useful technique with acceptable frequencies of morbidity and mortality for complex MCA aneurysms when conventional surgical or endovascular techniques are not feasible. For flow alteration with proximal or distal occlusion may be preferable to total trapping or for M1 trunk aneurysm to excluding occlusion of lenticulostriate arteries coming from one segment. In the cases of giant aneurysm causing mass effect, usage of bypass creation can be more radical method of treatment compared with endovascular method. Thanks for attention. If anybody has questions, I'm ready to answer.
Thank you, Professor Dubovoy. That was very nice lecture, nice videos. So thank you for sharing with us your experience. I believe it was useful for not only the young neurosurgeons, but also for us experienced. You explain us different techniques for different kind of fusiform and sacral aneurysm, complex MCA aneurysms, of course, and how to treat it. I would like to ask, is there any question from the floor or some comments, please?
Andrew?
Yes, sir.
Thank you very much for
Yes, Professor.
Thank you, Professor Kato.
very nice presentation. And the bypass is very seriously very important, the technique for all of us. especially the MCA aneurysm. You mentioned several types of the bypass. So how would you like to decide, such as a reconstruction or in the pulse of the MCA, or how much they need the flow of the MCA territory? How you can decide those things? Thank you very much.
Thank you, Professor. This question is very good because the choose type of bypass to revascularize of the MCA territory is very difficult question. I think we can use double barrel STA bypass to revascularize all of MCA territory. If I switch in one of the STA branch to one of M2 segment and another STA branch to another M2 segment, I think that this is enough to revascularize of all MCA territory. In cases when I don't use double barrel STA bypass because STA is bad, I use IMAX artery bypass because IMAX has a good flow in most cases, and this bypass is not very difficult, and quantitative blood flow of this bypass around 100 milliliters per minute. This is enough for all territory of MCA. In cases if I see the aneurysm don't have a thrombus inside, and I can reconstruct this aneurysm, I perform only protective single barrel STA MCA bypass, and during parent artery occlusion, this bypass performing revascularize of MCA territory. I need only 20, maybe 30 minutes to reconstruct this aneurysm, maybe less, maybe 10 minutes to puncture this aneurysm and reconstruct using different kind of clips. And in these cases, I use this technique. If aneurysm has thrombotic masses inside, and I think I don't perform a good reconstruction of M1 segment, of M1, M2 bifurcation, I don't use technique of reconstruction. In these cases, I prefer to perform bypass distally the aneurysm to revascularize of all MCA territory, and then I perform proximal or distal occlusion, or sometimes I may perform a trapping of aneurysm.
Thanks so much.
Thank you, Dr. Dubovoy. We have one question from auditorium. Dr. Harshad has a question. If you have the complex large aneurysm with the low distal flow, which is very low, as he said, how do you bypass, or which kind of intervention you use, you recommend?
Thank you, Harshad. This is a good question because sometimes after the fusiform or big aneurysm, we see the flow is very bad, distally very bad. In these cases, I perform only single barrel STA bypass to revascularize of distal territory. One single barrel bypass may perform blood flow coming through the one bypass around 25 till 50 milliliters per minute. This is enough in cases of bad flow after the aneurysm. Then you can perform trapping of this aneurysm or proximal occlusion.
Thank you. Thank you. Any other question or comments? Dr. Resch?
Professor
Yes,
Klaus
please.
has a question.
Please turn your microphone on.
Me, so now you should hear me. Thank you. This was, of course, a very nice presentation, excellent technique and excellent results. Thank you very much for that. And my question is, do you have a training laboratory? And how do you train the youngers, your trainees? Because this technique is very excellent, but there are only a few cases to use it, but the training should be very important in this technique, I guess.
Thank you, Professor Klaus. This is a very good question. Yes, we have a training laboratory. We have 10 training places for 10 young neurosurgeons. In our laboratory, we have mice and we training on the carotid artery on the mice to perform a technique end-to-end bypass and two-side bypass, and in some cases we perform bypass between two carotid arteries side-to-side fashion. And our young neurosurgeons, all of our young neurosurgeons has a training period in this laboratory, and then they come into our operation room and see the surgery, and sometimes perform assisting to neurosurgeons who perform in bypass, and many neurosurgeons who working around 3 or 4 years can perform STMCA bypass, single barrel STMCA bypass with cortical branch by someone.
Okay, very nice.
3 or 4 years neurosurgeon after training can perform
excellent.
STMCA bypass.
Thank you.
Thanks.
Thank you. Any other question, comments?
Well, we have another discussion, Professor Fawad Kirzad, who is the president of Neurosurgical Society of Afghanistan. Maybe we can take some comments from him. Professor Fawad, please, your comments.
Thank you very much. Спасибо большое. It was very good, and this was for young neurosurgeon. It was very good, but you know, in real in Afghanistan, we haven't the possibility for doing bypass or clipping the aneurysm, and we doing conservative management. And if in the case of ruptured aneurysm, we evacuate the hematoma if it's big than 30 milliliter. But other cases we doing conservative management, and it's good for our young neurosurgeons. That's they know, especially it was great. That's your conclusion. And when they got chance to going abroad for the training, they are ready for going to lab and doing some things. And we hope someday our young neurosurgeons become skilled with new and advanced technology and equipments. And thank you very much again, and thank you, Professor Sachin. And also, I like to say Eid Mubarak to our Muslim colleagues, and also we say condolence for Shinzo Abe, the ex-Prime Minister of Japan, and we like to say our condolence to Professor Kato and our Japanese colleagues as well. Thank you very much. Спасибо. Arigato.
Arigato, спасибо.
Thank you, Dr. Pirzad. Yes, we are all sad actually with the situation happened a few days ago in Japan. Professor Kato also welcomes us to all of you in Japan. We are full of those news and we are sad to hear that.
Thank you very much for your sympathy. Thank you so much.
Thank you. Dr. Dubovoy, Shahin, is there any question on order from the floor? Or if not, I have a few questions for Dr. Dubovoy. Shahin?
Yes, Professor. Please go ahead.
If there is no more question, I would like to ask you, Professor Dubovoy, as you show us in your videos and especially preoperative scans, you usually or almost always using the CT angio instead of DSA for the preoperative evaluation of the bypass diameter of arteries, flow, etc. As we know, the DSA is still the gold standard. So do you think that it's quite enough to use just CT angio? How we can be sure that the flow is good, and as we know, sometimes we cannot see the plaques on CT angio as good as on DSA and so. So do you think it's enough to use just CT angio, or is just based on your good experience so you can evaluate well even with CTA?
Thank you, Ibrahim, for this question. We usually perform CT angio in all of cases. In CT angio, we can measure the diameter of the artery, the diameter of aneurysms in three dimensions, the diameter of outflow arteries, and of course, we can see a plaque, calcified neck or calcified dome of the aneurysm, and sometimes the irregular shape of the aneurysm can be a predictor of thrombotic masses inside the aneurysm. But in few cases, we additionally perform a DSA, because DSA show us the distribution of the blood flow in dynamics in cavity of the aneurysm. Sometimes we so the aneurysm has a big in big and giant aneurysm, the flow inside this aneurysm circulating many seconds, and only then after that coming to outflow arteries. And we see the distally MCA territory is very poor and need to revascularize using different methods. In around half of all our cases, we perform initially before surgery DSA in addition to CT angio.
Thank you. Who doing that? Do you have the hybrid neurosurgeons who can perform DSA by themselves, or you use the radiology department or radiologists to do that?
Yes, we have a hybrid neurosurgeons. We have 4 hybrid neurosurgeons in our department who perform DSA for us.
Great. What about the usefulness of intraoperative ICG or ultrasound to check the flow after the revascularization, even by clips or bypass?
Yes, usually we perform ultrasound check-in in all cases. In approximately 1/3 of all cases, we perform ICG video angiography using indocin and in green to see the small perforators, to see the patency of the bypass, and to see the excluding of the aneurysm from blood circulation.
Yes, thank you. If I heard you well, yes, Dr. Ash, please.
I want to know if this ultrasound is a Doppler or if it's imaging. Okay, because I use very often, nearly in each case of surgery, the imaging ultrasound, because you can get very nice physiological data about the vessels down to 0.4 millimeters in diameter. You get a very good imaging intraoperatively whenever you need it. So this is my experience personally. The evolution of vascular surgery depend very much on the knowledge how to use the perforators and how to identify the perforators. I have seen many experienced colleagues being very desperate intraoperatively because they were searching for the perforators because they did not make a DSR before. So I personally like to have a DSR before to know exactly where are the perforators. We even have a problem in resolution, the angiography from classical angiography to DSR. We lost a resolution power. But for the perforators, it would be very important. And to find perforators intraoperatively in cases of bleeding might be very challenging.
Yes, great. We don't use imaging ultrasound, only Doppler, contact Doppler.
You will like it. Start it and you will like it.
Thank you.
It's a very short learning curve.
Thank you, Professor.
Another question, please, if you are not tired.
No.
Dr. Lee, if the time allows us to make discussion even longer. Do we have a time,
Yes.
Dr. Lee?
May I have a question?
Okay. When you perform the high flow bypass from the common carotid artery after the bifurcation and you find the external carotid, how far from the bifurcation you actually start with the bypass? Where's the point after the common carotid bifurcation? 2 centimeters, 4, or is dependence of the maxillary artery branches or what?
Your question about high flow bypass, yes?
Yes.
And proximal anastomosis on the neck, yes?
Yes. When you start, where you put the first?
Usually we use external carotid. Only in few cases we use in common carotid because the length of the interposition graft is not too high. In cases of using external carotid, the length of radial artery as interposition graft is good, around 20, 21, 22, 23 centimeters. But in cases, if you want to use a common carotid, you need to more longer interposition graft, but not every time you have this length of interposition graft. And I prefer to use external carotid 2 or 3 centimeters just after bifurcation of common carotid.
Okay. So you, for the external carotid, you mostly or always use the end-to-side anastomosis, not end-to-end, never.
End-to-side, yes.
Okay. You mentioned that you, if I heard well, maybe I'm not, usually not use the heparin, just aspirin, acetyl salicylic acid for the prevention. What about the Plavix, clopidogrel or something?
Usually we don't use Plavix because this is using of Plavix may increase intraoperative hemorrhage, and using only acetyl salicylic acid don't increase in intraoperative hemorrhage, and we don't so in our clinic post-operative hematomas in the neck or inside the cutaneous flap after using aspirin. I don't use Plavix.
There are some well experienced and well-known endovascular guys who sometimes trying to solve those troubles with the flow diverter stents and something like that. Do you believe in this story?
Yes, I mean, to place in flow diverters without open surgery, we use a combination of Plavix and aspirin. This is routinely used, but in open surgery, I just used only acetyl salicylic acid.
Yeah, okay. Okay, thank you. Any other questions or comments? Dr. Lee, Dr.
Sensei Hidayat Kimura, you had any doubt?
Oh, thank you. Yeah, I'm Hidayat Kimura. Спасибо, Duboboy. Yeah. Здравствуйте.
Nice to meet you, Hidayat.
Nice to meet you here. No, so your excellent lecture. I was interested to your excellent surgical series. I was so surprised as always. You performed the excellent surgical cases using a bypass, several kinds of bypass, and the high flow and low flow and the STMCA. And my question is, my concern is how to preserve the perforator if you perform the bypass installation. So actually, the MCA territory can be reconstructed by performing the bypass, proper bypass installation, STMCA bypass. However, sometimes the perforator could be terminated at the terminated end. So it may cause to the delayed occlusion of the perforator. So sometimes cause to the delayed patient deterioration of the neurological deterioration, sometimes 3 days and 4 days after the operation. And so in my personal cases, I use aspirin to avoid the thrombosis of the perforator, small perforator. So how do you comment about the preservation of the perforators? Thank you, Professor.
Yes, of course, we use aspirin too, and to prevent of occlusion of perforators coming from M1 segment, sometimes from M2 segment, we perform only proximal or only distal occlusion, not trapping, never, because the trap of the segment, including perforating arteries, after trapping, we have a patient with neurological deterioration. And if I see the perforators, I don't touch it, first of all. And then I use intraoperatively application of papaverine to enlarge the perforators in diameter. And of course, I use aspirin before and after surgery, and never use trapping.
So I mean, thank you. So your comment. So I mean, the proximal portion is clipped here, and sometimes they are arriving a small perforator right here. So small perforator terminates at the terminal end. So sometimes it hyperthrombosis occur at the terminates end. So and finally, the small perforator concluded in the thrombosis. So my concern is how to avoid the complication of the surgery, the surgical trapping. Yeah, it may be a great problem to perform this bypass strategy. The final problem should be resolved. Thank you.
Yes, you're right, because sometimes the placing the clip approximately the aneurysm can be closing the small perforator located near the neck, near the initial part of the fusiform aneurysm. This is a big problem, and if it's possible to use clip more proximally or more distally just after this perforator, or more proximally of this perforator to prevent of thrombosis of this is good, but not every time possible.
Yeah, thank you for your comment. Yeah, I learned a lot. Thank you. See you next.
Thank you, Timura.
Bye-bye. Thank you.
Thank you, Professor Dubovoy. I think so that we can conclude this part, first part of our session today. Dr. Leo Shahin.
Yes, Professor, I think we had an interesting session, and I would request Professor Andrew Bobo to be with us. I'm sure there'll be more questions, and at the end we'll go to our YNS speaker, and if there are any questions at the end, we can have a discussion again. So now allow me to introduce our next speaker. Our next speaker is young neurosurgeon speaker, who's Dr. Ishkuato Garyat, who's the head of Department of Skull-Base Surgery at Republican Scientific Center of Neurosurgery, Tashkent City, Uzbekistan. And he's going to talk on very important problem, that is whenever there are large meningiomas, how to tackle with the large meningioma, that is surgery of large meningiomas with preoperative embolization of major feeding vessels. I would request Dr. Garyat to share his screen and start his presentation, please.
Dr. Gairat, please turn your microphone on.
Yes, just a moment. Good. Are you hear me?
Yes,
Yes, we can hear you.
Oh, I think I have some problem with the video. Maybe you can see me.
No, we can't.
We're not able to see you yet.
Oh, I don't know what happened.
Maybe you can start. You can try sharing your screen.
Okay, I will start my. Just a moment. So, is it visible?
Yeah, we are able to see your screen and you are audible clearly, although we are not able to see you.
Okay.
So, yeah.
So, good day, afternoon, and good evening for everyone. First of all, I want to thank for ACNS, Fujita alumni, and especially Professor Kato for giving me such opportunity. It's great pleasure to see you all, even from far through the screen of my laptop. So today I want to share my experience of surgery of large intracranial meningiomas with preoperative embolization of feeding vessels. As it's now, as meningiomas are slow-growing extraaxial, usually benign tumor, which arise from special arachnoid cap cells. They are the most common tumors of non-glial primary intracranial neoplasms and consist from 20 to 30% of all primary brain tumors. Females suffer from 2 to 4 times more than men. Peak age is 46 years of life. An annual estimated incidence is 2.3 cases per 100,000 population. According WHO grading, mostly meningiomas are benign, And in 5-7% cases, they have more aggressive clinical behavior, atypical meningiomas, and in 1-2%, they have most aggressive form, anaplastic form. So, since the largest accumulation of arachnoid cap cells along the venous sinus and the skull base, the most common localization of meningiomas are parasitical, convexity, tuberculum cella, sphenoid wing, olfactory, cerebellopontine angel, and other locations are rare. So, because of the fact that the meningiomas are closely related with the dura mater, the vessels of the dura mater are also feeding vessels of the tumor. As it's known, the dura mater is fed mainly from the middle meningeal artery, with the exception of the medial parts of the skull base, where the menings are partly fed by vessels from internal carotid artery, and the posterior cranial fossa is fed by vessel from the vertebro-basilar system. This anatomical structure makes the middle meningeal artery the main feeding vessel of supratentorial meningiomas. So, meningiomas are hypervascular tumors, and since the feeding vessels are closely connected with the vessels of the soft tissues, bleeding can reach significant volumes already at the stage of approach. When the surgeon works in condition of bleeding, the risk of damage to normal brain and neurovascular structures increases. In addition, blood loss can cause blood transfusion and increase the time of the operation. Since the time when Manelfi in 1973 first described the method of embolization of meningioma feeding vessels through microcatheters, the method of embolization with modern embolic agent has been developing all over the world. So, indications, common indications are large size, extensive vascularity, skull-based meningiomas with difficult to access arterial supply, and some benefits like reduced operative blood loss, softness, and easier tumor resection, shortness of operation time. So, according to the literature data, many studies have been done regarding the effectiveness of embolization of meningiomas, embolizates, and the optimal time interval for surgery after embolization. The best embolizates are PVA particles and onyx from liquid embolizates, which allow total embolization and prolong the interval between embolization and surgery, which in turn leads to softening and the tumor easy removal. And there are no optimal time advice from the surgeons according to regarding to time period from embolization to the open surgery. It's from 1 day to the 32 or 20 days, and no one strict rules for this. So this is my this is my experience. We performed 15 operations on patients with large meningiomas using preoperative embolization of feeding vessels. The mean age was 45 years old by localization. Patients with meningioma of sphenoid wing was predominated. The feeding vessels was mainly the middle meningeal artery and on here. So The feeding vessels will bind the medial meningeal artery. In 3 cases with meningiomas of skull base, feeding was additionally supplied from the ophthalmic artery, the meningopituitary trunk, and from the internal carotid artery. So we used combination as an embolic agent. We used combination of NBCA, lipoidol, gel foam, and onyx a couple times. When we started to embolize patients with large meningiomas, we faced several problems. What kind of embolization and what is the optimal time of operation after embolization? In our observation, when the operation was performed after 3 or more days after embolization, the blood loss was significantly greater than in cases when the operation done immediately the next day. Regardless of the type of embolic agent. So from this data, we can see that we done operations. The interval between the embolization and surgery was from 1 day till the 8 days, and other. In addition, other problem we had with the ability to pay of patients. So we had to look for a cheap and effective embolic agent. Such an embolic agent, in our opinion, was gel foam. It's cheap, easy to use, but it's impossible to prolong the interval between embolization and surgery. Due to short time for tumor recanalization. So we have started to do all surgeries the next day after embolization. We couldn't reach tumor softness, but the bleeding was significantly reduced. Here are some examples. Patients with sphenoid wing meningioma, very hypervascularized meningioma, and subtotal embolization was achieved in this case. Here, the more than 2 feeders was in this case. Here's a giant meningioma, convexal parasagittal meningioma with extracranial growth and spread to the soft tissues. Here also we achieved total embolization. Here was both sides, from left side and right side feeders to the tumor, and more than five feeders, feeding vessels was here, and predominantly it was middle meningeal artery and some feeders from the superficial temporal artery. Here also we achieved the total embolization just with spongostan gel foam, I mean. Another case with sphenoid wing of meningioma, here this tumor take feeders from the middle meningeal artery only, and that's why we can achieve, we achieved total embolization. Another example, here we can see parasagittal tumor, which fed from middle meningeal artery two feeding vessels, as you can see. So we blocked the meningeal medial artery just from the base of the vessel. Then we can close it totally. Another case, in this case, another sphenoid wing meningioma case, and here feeders was from middle meningeal artery and partially from the internal carotid artery. That's why the embolization was here. We did embolization just from meningeal artery, and that's why we achieved the subtotal embolization. Here some video from the intraoperative videos. Here the giant parasagittal tumor, and the feeders was totally from middle meningeal artery, and the total two vessels, as you can see, both of them was embolized. Here two vessels, as you can see, and as you can see, the tumor has a pale shade and totally devascularized. Any signs of bleeding, even without using any hemostatic agents, we are working. Opens the dura. Oh, sorry. Opens the dura. And here you can see tumor totally devascularized and pale shade. Embolization was done only with gel foam, and the surgery done just next day after embolization. And blood loss here was approximately 160 millimeters, and time of surgery was 200 minutes. And Simpson 1 resection was achieved. Here you can see. And in the postoperative CT scans, is visible that tumor totally removed. It's a small venous vessel, and another case with a sphenoid wing meningioma, middle type. Here, as you saw before, small feeder from the ophthalmic from the ICA still feed the meningioma even after embolization. But in the video, we can see that the cranioorbital approach was done here, female, 56 years old, and as you can see, despite of some bleedings from the surrounding tissues still on, but tumor itself pale and not bleeding. Tumor firstly was debulked by using ultrasonic aspirator. Here you can see that the tumor itself is pale and no signs of the bleeding. After debulking, the tumor removed and detached from the MCA and its branches. And then totally removed, but because of the complex placed this tumor, we achieved only Simpson 3 grade by just a little part on the carotid here under the hemostatic agents was here we can leave just a little part of the tumor. This part was coagulated. So, just a moment. So, in a conclusion, I can say that the use of preoperative embolization of meningiomas significantly reduced the risk of intraoperative blood loss and all related complications, shortening the duration of the operation. The use of embolization also increases the radical removal of the tumor. Thank you for attention. I think my presentation not so huge and interesting, maybe like Professor Dubovoy's presentation, but I have shared only my experience, and we have started recently this method, and just 15 operations, and we will keep on research and accumulate our experience and our data, and maybe in the future I will do more wide presentation with meningioma, giant meningiomas with using preoperative embolization. Thank you very much.
Thank you, Dr. Gairat. Nice presentation, nice experience, 15 cases. That's actually nice area. Before I make a comment, I would like to ask the audience, is there any comment or question? Yes, Dr. Gopal from Nepal, hands up, please, Dr. Gopal.
Hello, everyone.
Hello.
Congratulations, Dr. Gairat, for doing excellent job. All of us faced with such meningiomas almost daily in our practice. I have one or few comments, like what makes you to decide which type of these meningiomas require preoperative embolization? Because not all meningiomas will go for embolization. Are there any basis like size of the tumor or vascularity based on any specific MRI findings? Which type of meningiomas do you send for embolizations?
Thank you for question, Dr. Gopal, and nice to meet you. According to your question, so all great size meningiomas, I agree with you that not all meningiomas are must be embolized, and some firm meningiomas, white meningiomas, can be operated without embolization. And but when we do CT or MRI images with contrast enhancement, if the meningiomas on pictures colored intensively, that means the meningiomas has a vascularity, hypervascular meningiomas, and bleeding during operation, especially during the approach, and detach the tumor from the brain tissue. In this time, we had many times we had problems with the bleeding, and sometimes we cannot separate these tumors will be bleeding, whether it will bleeding or not. And that's why we have started to embolize every big tumors.
Okay.
Every big tumors. So when you see the pictures, it's hard to predict will be it tumor, this tumor, whether it will be bleed or not. That's why every big tumors we try to embolize.
And in one case, you took 8 days to operate after embolization. Was there any specific reason? For surgery.
In one case, what? I understand. Don't understand.
You did embolization, and after 8 days, you went for surgery. So there was a gap of 8 days. What we practice is
8 days. Yes. As I said before, the gap in the days from embolization to the surgery is not fixed according to the world literature, and every authors try to explain their own experience, and that's why we have started. We have started to experiment, like what if 3 days, what if 4 days, what if 8 days and a week. But all cases when we operate more than 3 days before, more than 3 days later, in all cases we have got more bleeding than in cases just next day after embolization. That's why I think this is our experience, and we maybe in the future, if we take more modern embolic agents, maybe we will start to operate 5 days, weekdays after. But now with gel foam, only 1 day, no more.
That's what we practice. We also do it within 2 days because we regularly use gel foam because of the cost factor. And within 48 hours, we tend to operate. Thank you, Dr. Garrett.
Thank you. It was nice to meet you.
Thank you, Dr. Gopal, for your question. Any others? Dr. Resh, any comment?
Well, of course, the vessels are a major problem of meningiomas. But however, before surgery, in the planning phase, in the planning time, we like to know if there are some PR feeders coming from the brain itself. We would like especially to know if the meningioma will respect the arachnoid membranes. This is a very important point. And the third important point for the procedure is the consistency of the tumor. What kind? Is it a hard one or is it a soft one? This is very strongly has a very strong impact of the surgery of these kind of tumors. All these questions, I'm sorry to say this again, can be answered by ultrasound. If you make an ultrasound before you open the dura, you will be answered all these questions, and the ultrasound will show you the main feeders, and this will predict your strategy, because you have to make a strategy to go very directly to these feeders, which can be in nearly all cases reached very early, depending from the kind of approach you are doing. So if you know where are the feeders, you'll know what kind of strategy you have to do, and you will know if you have to pay attention to meet accidentally PR feeders. PR feeders also tell you that this tumor might not respect the arachnoid membrane. Before CT era and MR era, the radiologist identified the different kind of tumors by the vascular pattern. So each tumor kind, even the gliomas, had a fingerprint, a vascular fingerprint. This vascular fingerprint can be identified extradurally by ultrasound also. But moreover, you can identify the flow of the vessels. The question Yashakil always asked to us was, what is the character of this lesion? I want to know the character of this lesion. Will it be dangerous? What will it do to the brain? How will the brain behave when I take it out? At this character of the lesion, the issue on this topic, all these things can be answered by ultrasound. So I would recommend in many cases rather ultrasound examination before opening the dura than to embolization. This is my answer.
Thank you, Professor Klaus, for your recommendation. And I think we have ultrasound in our operation, and I think we will use your advice. I think we can use, and maybe in the next cases we will use ultrasound diagnostic interoperatively. Thank you for advice.
Thank you, Dr. Gairat. Professor Kato, do you have any comments or suggestion?
Thank you, Gairat. So long time no see.
Thank you. Nice to meet you too.
Yes, excellent presentation. And if you want to know how much the necrosis, the part of the tumor, if you have a MRS, so MRS just so you can check the parts component. You can check. Then if it's increased, maybe the more necrotic part. It's a good timing to do the surgery.
Yes, I agree with you, MRI, but to get the necrotic changes, it needs more days. But gel foam not allow wait for many days. It's because of the recanalization. Gel foam, when we use gel foam, we cannot wait till the necrotic changes. That's why, of course, in the future, maybe when we will have some modern embolic agents, I will use your recommendation, of course.
Thank you.
Thank you. Thank you very much. Nice to meet you again.
Yeah, very, very excellent lecture. Thank you.
Thank you.
Ibrahim?
So, Pirzad, any comment?
Okay. Salam, Dr. Gairat.
Wa alaikum assalam. Wa alaikum assalam.
Thank you very much for your
Dr. Fawad.
nice presentation. You told that it's small, but this is a proverb that think big, small start, act now. And you start small and don't worry about it. It was great. And we also have problems with bleeding during the operation for brain tumors. Sometimes we had also problem with the meningioma attached to the sinus, especially in superior sagittal sinus. And this is the bleeding of this kind of tumors. That's sometimes it's very trivial. And I like to know your opinion about and also other colleagues about the meningiomas attached with the sagittal sinus, especially superior sagittal sinus. And your presentation was great. Thank you very much and congratulations. Rahmat.
Thank you. Thank you, Dr. Fawad. Rahmat.
Thank you to both of you. Any other comments?
Can we take comment from Professor Andrew Davidow, because since he is here, a senior faculty? May I request Professor Andrew to please make a few comments about Dr. Gairath's presentation and about your thoughts about preoperative embolization for meningiomas? Professor Andrew? Yes.
Yes, I have a small question to Gairath. Dear Gairath, thank you for very nice presentation. My question about your opinion about possibility of embolization intraossal meningiomas. Do you have this experience, or if not have this experience, what your opinion about possibility to reducing blood flowing from embolization after embolization of intraossal meningioma?
Thank you for question, Professor Dubovoy. Of course, when the meningiomas are growing intracells, even after total embolization, you can see the bleeding. You can see the bleeding during tumor removal. But I think in this situation, I will do embolization, because without embolization, bleeding will be more. Then if I correctly understand you're asking about what about the intracells whether will be some benefits or not, yes?
Yes.
From the I think there will be benefits because without embolization of intracells meningiomas, the bleeding will be more. And that's why I think in these cases, I will do embolization. And I had one, I had one case, if you saw the picture, intracells, and that meningioma growth till the soft tissues. And there we have done total embolization, but the bleeding was still on during operation because of the bone. And but I think without embolization there would be more bleeding than I had. Thank you for your question.
Thank you. And one more question about meningiomas with transition to orbital to orbit. Do you think about embolization of this type of meningiomas? Is it safety for orbital compartment or not? Is it safety for blood supplying of eyeball or not?
Thank you for question. This is a very interesting question, and as I said before, maybe I didn't stress in my presentation, but this kind of meningiomas as usually takes feeders from ICA and the external carotid system. And because of the risk of injury, embolization or infarction, the vessels from the internal carotid system, such as ophthalmic artery or other small vessels, we don't embolizate from internal carotid artery. We just do only from the external carotid artery and meningeal arteries, and that's why in these cases we can't reach total embolization. And I think embolization from the internal carotid artery is dangerous. That's why we as usually don't do embolization from the internal carotid artery. And maybe with getting experience, maybe we will start embolization from the internal carotid artery and feeders from the branches of the internal carotid artery. But now nowadays we don't do this because of the dangers of the embolization of the ophthalmic artery.
Okay, Gairat, my question about safety of embolization intraorbital meningioma, safety for eyeball blood supply. Is it safety or not?
Intraorbital.
Yes.
Yes. It depends. It depends on the feeder. Intraorbital meningiomas as usually take feeders from the ophthalmic artery. That's why these kind of meningiomas is usually not so big, not so large, and I think no need embolizate to do the embolization intraorbital meningiomas, in my opinion.
Yes, and you don't have such experience.
No, I don't have such experience. As I said before, we do embolizations only in large meningiomas. Small meningiomas, no need to embolization.
Okay, thank you so much. Thank you, Garat.
Thank you for question.
Thank you, Professor Andrew Davido, and thank you, Gairat. I think Dr. Claudia Gomez is there from Colombia. Dr. Claudia, can you introduce yourself and ask your question?
Good morning for all the audience. My name is Claudia Gomez. I'm skull-based surgeon from Colombia. And I have a question for Dr. Gairat and for the audience in general. Do you have some special cases where you definitely don't consider embolization? And my second question is just about it. For example, in cases of anterior skull-based surgeries or anterior skull-based meningiomas, do you use embolization? Because my perception and what I usually do is that I prefer don't have the risk of blindness for embolization of, for example, olfactory growth meningiomas, even in huge cases. And I never embolize those patients because I'm afraid about blindness. But I would like if some of you have some experience using embolization in that cases. Thanks.
Thank you very much, Dr. Claudia, for interesting questions. Yeah, I think first question is a continue of the second question. Yeah,
yes.
Of course, it depends on the feeders. Before operation, if we see the large meningiomas, we do angiography. If the feeders are coming from the ophthalmic artery, it's dangerous. As I said, as I answered for the question to Professor Dubovoy, if the feeders from the ophthalmic artery, of course, because of the risk of blindness, post-embolization blindness, we don't do as usually embolization from the ophthalmic artery. And if some relations with the feeders of the, of course, in some, in cases of, in cases of the meningiomas anterior skull base, we did the angiography, but in couple two times we had, in two cases we had angiography, but in both cases feeding was partially from the ophthalmic artery. That's why we didn't embolization. And in these cases, if the feeders are related with ophthalmic artery, I think, in my opinion, it's very risky to embolic after embolizating blindness. That's why we didn't do this.
Thank you. Thank you very much, Dr. Gairat. I think Dr. Klaus wanted to make some comments. Yes, Dr. Klaus?
This was a very, very good question, because it is very dangerous to embolize if the optic canal is involved. And there is a embryological reason that has been shown by the famous anatomist Johannes Lang from Germany. And this embryological reason is that in a small part of the optic sheath, from where the tumor can arise, has a common vascularization with the optic nerve. In a very short area, let's say about 3 or 4 millimeters, embryologically they have a common vascularization. The dura of the optic nerve and the optic nerve itself. This is the reason why we made people blind in the past when we radically operated optic sheath meningiomas. If you left a small piece that is necessary for the preservation of the vascularization, then you might have a good result. But most surgeons in the past did not leave this part of tumor, and so they made the patient blind. Second, a very, very rare variation is that the ophthalmic artery may arise from the middle media meningeal artery. This is very rare, but the neuroradiologist should be able to recognize it. And in such cases, of course, you cannot embolize. And also, yes, thank you. This was my comment.
Thank you. Thank you for a comment and advice, Dr. Klaus.
Okay.
Thank you very much. So, any other question or any comments from anybody?
Yes, I have, but I'm waiting if there is others want to say something. If not, yes, actually, I wait to see how discussions goes on. And at the end, Dr. Resch actually started with the discussion I would like to talk also about. And also, Claudia. Dr. Gairat mentioned actually that if I understood well, that the main criterion or only criterion was actually large meningiomas or their size. I think so that if this is the main reason to embolize the tumor, not vascularization, not enhancement of contrast MR, not confirmation if the tumor is calcified or not, also the localization of the tumor. As we know, there is big differences between the behavior of the tumors on the dorsal meningiomas, falci and parasagittal with skull-based meningiomas. Also, as the Professor Resch told us, even the small meningioma, which involve the optic canal or cavernous sinus, olfactive groove meningioma, tuberculum cellae meningioma, sphenoidal ridge meningioma, they are all different in their, let me say, blood supply. So I'm not sure that the main reason or only reason for sure the size of the tumor is for decide to embolize or not. Even more, if we have some kind of calcified meningioma or simple dorsal meningioma, I don't think so, which is actually quite far from the large vessels and are not so easy to embolize them. I'm not sure that is usefulness to embolize all this large meningioma. And otherwise, when we have the skull-based, anterior skull-based meningioma, which have the supply from the bone, from the anterior pharyngeal branches, arteries, and so PL supply, I don't think so that we will have too much benefits from the embolization. What would I like to say is that we should look to not only the size but also the enhancements of MR. the localization of the tumor, involvement and contact and relationships with the vascular and neuronal structures, and then decide to embolize or not. This is my first comment. And of course, if you have the small piece of the tumor who are going through the optic sheath, through the optic canal, surrounding the optic nerve or even carotid, and maybe having the cavernous sinus part of the ICL, some small branches which supply the skull-based tumor, the embolization, I don't think so, could help us to solve this problem, which is usually the biggest problem for this kind of surgery. I'm talking about the skull-based surgery. Also, when we're opening the optic canal to preserve the optic nerve, no drilling, and so we are learned that from Dolence and other Samuel Mefti, all those skull-based guys. No drilling there, no touching too much optic nerve. Don't press. And could you imagine what the embolization in this region could do us? So I will divide the actually indication for that, but it's my opinion, of course. What would I like to ask you is actually why to wait for 2 or 3 days after the embolization, because we have to undergo the patient 2 times to general anesthesia. What we do in my department, but to be honest, I don't use too much embolization, even for the large meningiomas. But sometimes, yes, we do it, especially my young colleagues like embolization much more than me. And what we do, we doing the surgery at the same time, just to prevent the patient to put under the general anesthesia a few times. And also we're using the onyx much more than the gel foam. And of course, for very, very short list of indication, for example, the large temporoparietal meningioma, which has supply mostly from the external carotid and so on. So my question is, do you use the onyx sometime, and why you are waiting? Yeah, we know that there is no the real confirmation to wait 1 day, 3 days or something, but why put the patient to general anesthesia 2 times in 2 days?
So, as usually, we don't use
2 days.
Yes, I understand. As usually, we don't use general anesthesia during embolization. I'm not the endovascular surgeon, but our endovascular team do it under local anesthesia without general anesthesia. That's why I think not. We don't do the general anesthesia twice, and that's why first day. Sometimes it takes more time, and the patients are tired under embolization, after embolization, and go straight to the OR and continue operation long time. And that's why after embolization first day under the local anesthesia, they rest and go to the open surgery next day. And more than 2 days, 3 days for gel foam is not useful. Yeah, that's why we do. As I understand, you are asking why not directly to the OR? Yeah.
Yes. Even doing with fibrin glue or something like that, onyx or something during the intraoperative in the neurosurgical OR suit, you can put the gel foam and continue after 2 hours with the surgery. You will have the almost same results, as I know.
Oh, I think because of the time, and embolization sometimes takes hour on the 1 hour half and 2 hours. That's why, and it's a long surgery day. It's easier to take to the OR next day than the OR after in the next part of the day, I think. And That's why we do it in 2 days.
Okay, thank you.
Thank you for question.
Thank you very much, Dr. Gairat and Professor Ibrahim for that discussion. Are there any other comments or any questions from any panelists or delegates? If not, then we've come to the end, the closure of today's webinar. I think it was an interesting webinar, and I would request Professor Yoko Kato to make a few closing remarks before I make the announcement of the next webinar. You have to unmute yourself, Professor.
So thank you very much for Rush, you want to say something?
Yes.
Please.
I want to make a personal comment. I want to thank very much Professor Kato that she did not refuse to invite our Russian colleague, because in science we should keep the communication open, whatever happens in politics. Thank you.
Thank you very much. So tonight's the Andre and also the Gairat, the two speakers, those are the very excellent, and also that we had a very nice scientific questions. Of course, according to the situation, I think maybe Dr. Gairat, he cannot use they can use only the particle embolization material, I think. In the future, they can have some onyx or some NVCA. And also, I talked before, not MRI, but MRS, MRS tell us how much the necrotic part. Then we can, we can suspect when is the best
Yes,
timing.
I misunderstood you. Yeah,
okay.
of course.
Best timing to do the surgery, you see. Yeah. Anyway, Andre is one of the best vascular neurosurgeon at least in Russia. Maybe the next time, Andre, maybe you can show us some bypass hands-on techniques through the YNS webinar. Thank you very much. It was excellent lectures. Discussion?
Thank you.
Thank you very much. So,
thank you very much.
I just to announce that we conduct this webinar the second and fourth Sunday at the same time. So next webinar will be on 24th of July, that is on the fourth Sunday of this month. And I would like to invite you all for our 13 ACNS conducted in October. Thank you very much. And that was the promotion video. I would request you all to send your abstract and your junior colleagues and residents to send their abstract for the Congress. And with Dubovo, Dr. Gairat, Professor Ibrahim, thank you very much.
Thank you.
The lady, Dr. Nargiza.
Thank you very much for invitation, which I got from my teacher, Professor Andrei Dubovoi. Unfortunately, I joined a bit late, but I was enjoying with the last presentation from the Dr. Gairat. I'm also from Uzbekistan, but currently doing my fellowship in India. So I hope I will get opportunity to meet my colleagues from Uzbekistan
It will be nice. Yeah, nice to meet you.
Thank you.
Thank you very much.
Welcome to the Uzbekistan.
Thank you.
Thank you very much. Please share your email address with me. I will write you and I'll send you the updates of the webinar in future. Dr. Dilshad,
Yes,
you're there.
definitely.
You were quiet. You want to say something?
Of course, I will share.
Hi, everybody.
Hi,
Thank you.
Dilshad.
It was nice. The discussion club discussions, two very actual topics of neurosurgery. And it was nice to see you again. Me also joined a bit later, but it was nice to listen to discussions, yes, especially the last topic, and it became very actual, yeah.
Yes. Thank you.
Thank you.
Thank you very much. I think it's too late in Nagoya right now, so it's a time to wind up.
Thank you.
Thank you. Good night.
Thank
very
you.
much. Okay.
Bye-bye.
Bye.
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 Sensei, bye bye.
Thank you.
Bye for
Thank you. See you next. Thank you. Bye-bye.
Thank you, Kimura Sensei. Thank you very much.
See you. Thank you.
Thank you. Bye-bye.
Hi,
Bye. Bye. See you next.
Bye.
Bye-bye. Thank you.
Last presentation. Thank you.
Thank you. Thank you.
Bye.
Yep,
Thank you.
very much.
Thank
Bye-bye.
you.
Thank you.
Bye-bye.
Very good.